The cranial nerve examination, I think, is the bane of most doctors' existence. I remember trying to memorize this when I was a medical student, and we all had mnemonics for the 12 cranial nerves. On old Olympus, towering top, a Finn and German viewed some hops. There was actually another one a little bit less acceptable that I can't tell you, but many of you know what it is. In any case, that was how we memorized them. We couldn't figure out why we needed to know these cranial nerves. Why did the 19th century neurologists put this into the neurological examination? I mentioned that the neurological exam evolved. Why did it evolve to include the cranial nerves? Why did it have the honor of 1/7 of the neurological exam? Well, of course, in those days, in the 19th century, these neurologists were seeing a lot of diseases that affected the cranial nerves, either because they affected the meninges, the pachymeninges or the leptomeninges, or they affected the skull. And they couldn't recognize these diseases any other way. These diseases, many of them didn't affect the cerebrum, so they didn't produce aphasia and apraxia. Some of them didn't produce hemiparesis or weakness, but they were very important illnesses. And of course, the big two from that period were tuberculosis and syphilis, which were the most common diseases that the neurologists faced. And they tended to affect the cranial nerves. They caused pachymeningitis, which means meningitis of the dura, caught the cranial nerves coming and going. The cranial nerves got into the exam. They've stayed in the exam. And you wonder, well, why are they still in the exam? We don't have that much tuberculosis and syphilis, although we still do have it, of course. And that's because, of course, other illnesses have come to replace tuberculosis and syphilis in the modern world and take on a great importance in their own right. And among those, of course, is cancer of the nervous system. So people are surviving cancers that would have killed people in the 19th century, and those cancers are involving the leptomeninges and the pachymeninges, and they're causing cranial nerve problems. Some of them metastasize to bone in the skull, where the cranial nerves are going in and out through various holes in the skull. And prostate cancer and breast cancer would be two good examples of that. And furthermore, of course, there are cranial nerve diseases which are specific or almost specific to cranial nerves. I guess the prototype there would be Bell palsy, facial palsy, which has always been there and is still there, although it has a few new causes, such as borreliosis or Lyme disease. So cranial nerves still are important. It isn't really useful, I don't think, to use some mnemonic and just sort of routinely go through them in some mindless way. So what I do is recommend that people cluster the cranial nerves in their mind according to function, and think of it that way, and that way you can think through the cranial nerves in a logical fashion. The first cluster of cranial nerves is really a cluster of one, and that is the first cranial nerve of the olfactory nerve. Many people skip this. As you know, a lot of people write in their exam 2 through 12 intact, cranial nerves 2 through 12 intact. I don't know why people do this. I sometimes come up to a person that's written that and I say to them, why? What do you have against the first cranial nerve? Why don't you test it? Is it difficult to test or something? You think it's not important? It can be very important. Of course, there are diseases that affect the first cranial nerve. Head trauma is a very common example of that. People hit the back of their head, fall on their back of their head, get a contrecoup injury to the olfactory bulb and lose their sense of smell, and as a result of that have an abnormal sense of taste, which very much interferes with their life. That's a fairly common one. What people didn't know a long time ago, but do know now, is that disorders of the olfactory bulb are very early manifestations of some very important neurodegenerative diseases, and the most important of those is Parkinsonism. In fact, we believe that Parkinsonism almost always affects olfaction if you look for it carefully. So there's many reasons why we should check olfaction. It's not acceptable to write 2 through 12 intact. But just like the whole rest of the exam, you may or may not decide to test it. That depends on the history, the circumstances. But there's no reason to just out of hand ignore the first cranial nerve. In fact, I always carry this little container with the Roman numeral 1 on it. That stands for the first cranial nerve. And I carry this with me all the time. I keep it in my pocket so that I can test patients on the service when I'm walking around the wards, not just in my office. So Alan, take a smell here. We're not otorhinolaryngologists, so we're not going to tell him to cover one nostril or the other. I just want to know, can he smell this? Can you smell it?
I smell something. I think
What
it's
is
coffee.
Coffee is correct. So it's coffee. This is kind of old coffee, not very good coffee. I've got to replace that. It's a simple thing. You can keep peppermint, the smell of peppermint, in a small container like this, keep it fresh. Just takes a second to do it. Well worth it. Well worth it. And sometimes, of course, critical. A person comes to you saying, I've lost my sense of taste. You say, have you had any head injury? Well, I fell on the ice last winter, hit the back of my head. You begin to think to yourself, well, this is probably an olfactory bulb contusion, a contracule injury. Check the sense of smell. So that's the first cranial nerve. I think that is a cluster of one. Then I take the next group and I cluster them around the eyes. Which cranial nerves are involved with the eyes in one way or another? Well, this is a big cluster. This is going to help us to understand the cranial nerves. Let's think through it. There's cranial nerves 2, 3, 4, 6, and 8 to some extent, as you'll hear in a minute. All are related to eyes. So, in fact, if I carefully examine his eyes and I exonerate his eyes are normal in all respects, I've actually screened cranial nerves 2 through 8. So if he has a sense of smell and his eyes are intact, I've gone already from 1 to 8 out of 12. That's not bad, huh? Now we have to have an organized way of examining the eyes. The eyes, of course, involve the eyeballs themselves, the pupils, and the connections to the central nervous system. But they also involve the lids and the eye movements. And so we're going to check this in a fairly organized sequence. Let's start with the second cranial nerve. There's 3 things we can do with the second cranial nerve. The first one is the one I think most people forget, and that is we can look at it. We can see the second cranial nerve. It's the only part of the central nervous system we can see. You know that the word nerve is a misnomer. This is not a nerve. It's actually a tract. But it unfortunately was called a nerve by the old neuroanatomists, and so we're stuck with second nerve or optic nerve. You can see it. You should never pass up the opportunity to see it. There are many reasons why you should look at the optic nerve. I'm going to use my own little ophthalmoscope this time that I carry in my pocket when I'm on service. And I do that for a reason that a neurosurgeon gave me. When I was a resident in neurology, we had a neurosurgical rotation. And the chief resident on the service had a little ophthalmoscope like this. And we were sort of derisive about that and said, well, you know, these neurosurgeons, they don't know how to look at eyes. It's such a cheap little small ophthalmoscope. And he said something to me which has always stuck in my mind. He said, you know, it may be a small, not very good ophthalmoscope, but at least I look at everybody's eyes because I always have it with me. You may have a nice ophthalmoscope on the wall back in your office like we have here, but that's not with you, so what good is it? And that really is true. Just get good with a nice, simple, small ophthalmoscope, and for neurological purposes, it's good enough for most purposes. Let me remind you how to use it. We turn the light on. We set the lenses at 0. We take all the lenses out. We have him look over my shoulder at something of interest to him on the wall, and I come in at an angle like this. So I'm going to stand back about this far and look in there, and I can see the redness of his retina. That's the red reflex. He's looking off in the distance. The optic nerve is coming out toward me, so I'm going to come right in to the optic nerve. I'm just going to come right in. He's looking over my shoulder. Don't look at me. And here I am. A couple of little points about this, sort of side points about being a doctor. You're going to come up close to the person. I put my hand on the person's shoulder, and I come in like this. There's far too little touching of patients in the modern era. People sit on the other side of computers. They don't touch patients. People don't like that. Doctor needs to touch the patient. We already did it a little bit, right? We listened to the heart, felt the carotids, and so on. This is an opportunity to get close to the person and look in the eye. And the only way to get good at this is to practice. That's why we call it the practice of medicine. There's no other way. You can look at retina photographs, memorize them all you want. You need to look in the eye, every case, patient after patient. It's good for the patient-doctor relationship. It's very, very good when you're going to reassure the person. The person comes to you with a headache. They're frightened they have a brain tumor. You're not worried that they have a brain tumor. It doesn't sound like it. The exam is otherwise normal. They're not convinced. It's very, very useful for you to look in the eye. And as you're looking, you say, I'm looking right in the back of your eye here. I can look right to your brain. I can actually see your brain, which is not a lie, is it? I'm looking at the optic nerve. Optic nerve is a tract. I'm actually looking at the brain. I'm looking right at it. It looks very, very good. Looks good. I'm already treating him You see? He's already hearing me say, this looks good, this looks normal. And I get a look at the optic disc, and of course I want to see its color, I want to see the margins of it, I want to try to see venous pulsations. You should be able to see venous pulsations. You have to practice. Pick a big vein coming out of the disc, look at it until you see it. Practice with your spouse, with your brother, practice until you can see it. And then another thing to do is to look at the fovea, and the way to do that is to say, look right at my light now. Will you look right at my light? And I look right at the light and I see that little dimple of the fovea. I can see that. So I've examined the optic nerve. I'm looking at its color. It shouldn't be chalk white. It ought to have a little pinkish color to it. Now obviously my describing that to you isn't good enough. You're going to have to go and do this yourself. Look at a lot of people. Then you'll begin to learn when it's too white, when it looks atrophied. And then you'll look at the fovea and see what that looks like, that little dimple. It ought to be something that you're used to seeing, and I would say there's very few patients, almost really regardless of their complaint, that you wouldn't do this. This is part of what I would call a screening neurological examination. And everybody you're going to see, you really ought to look in there. So that's the first part of the second cranial nerve. We've looked at it with our ophthalmoscope. Then we're going to test visual acuity. One eye at a time. I've got a chart here on the back wall. If you don't have the chart, you can carry with you a little card, which is fine. Let the person hold it any distance they want. You're not an ophthalmologist for this purpose, so if the person has lenses, let them use their lenses. We're interested in the neurological problems, not the ophthalmological problems per se. So if you wouldn't mind standing right here, Alan, you should be 13 feet from this chart. But I'm not going to measure it exactly precisely for this purpose, but this particular chart says 13 feet away. Let me just have you hold this up like that yourself. So we're covering his right eye, his left eye, his left eye, his right eye is open. And how far down can you read? Can you read this line?
Yes.
Can you read it to me?
Z, H, C, S, R.
That's very good. And let's switch it to the other side here. How far down can you read there? You read that one again?
Yeah.
Read it in reverse. Start the other side.
R, S.
Good. How about below? Can you read the next one?
Yes. In reverse or in?
Forward order.
Forward is S, Z, R, O, N.
Right. So he's actually better than 20/20 vision. Good. Sit down. Now, if he had trouble seeing with either eye, the next thing I would do is I'd put this pinhole over here. And a pinhole corrects for most refractive errors. See that little device with the little holes in it? And those of you who are my age, or maybe a little bit younger, will have noticed that you're going to have trouble reading up near. Right? That's presbyopia. You start holding things further and further and further away, and then finally you get lenses. Take your glasses off if you're one of those people and look through a little pinhole. You can make your own pinhole. Just take a card, put some pinholes in it, cover the hole with a pinhole, and you'll notice that you'll be able to read as if you had lenses on. What you've done is corrected for the refractive error. It's useful for neurologists to do this because we're not as interested in the refractive error. We're interested in neurological visual loss. So testing visual acuity is the second component of testing the second cranial nerve. And the third thing is visual fields. Visual fields are very important to test because they're one aspect of the exam that patients can't complain about. That is, they don't know that they're having a visual field cut. Patients, people, and even doctors don't really understand the concept of visual fields. That is, that there's an extra personal space and that we have a map there of visual space, a mind's eye, and that's in both eyes. That you see to the left with both eyes, not just with your left eye. That's not something people understand. Now there's different levels of sensitivity that you can test this. I'll show you a couple of simple ways that you can use on a ward with a very sick patient, somebody who's more cooperative, and then ultimately somebody who's very cooperative. Let's start with the simplest method. Somebody's on a ward, they're confused, they have trouble looking at you. Look at my face. What I might do is just give him a visual threat like that. I give him a visual threat from this side, a visual threat from this side, and I'm watching his eyes blink. Now after I do it once or twice, of course, he stops blinking. So you have to be prepared the first time to look. And that means he sees my visual stimulus coming. Another thing is, of course, to flash up something interesting, and the person will see it there and look. You'll know that they're seeing up there. And we just check in the 4 quadrants like this. If you want to put something up more interesting, you could put up a $10 bill or a $100 bill, you know, suddenly flash that up there, person sees, they'll look up there. You can pick up a pretty subtle visual field cut like that, even in a confused, inattentive person. If a person's a little bit better than that, but still not perfect mentally, you might say, look right at my face, right in my eyes, and tell me how many fingers you see go up. How many was that?
2.
Good for you. And how about now?
5.
And now?
1.
And now?
6.
Notice I'm giving him 1, 2, and 5 are the only 3 signals I give. I don't give 3 and 4. They're too close together, hard for people to see. And first I give it single in one visual field, then I give it together. I'm looking for so-called visual extinction, the inability to see them simultaneously in the 2 sides, which would be a parietal lobe problem. And you see how I do it. 1 quadrant, then another quadrant, then both quadrants, and the same thing. Both eyes open, so it's not a perfect test, but it's quick. It's very good in a slightly confused person. Right? Somebody who doesn't get the idea that I want you to look at my face, and don't look out there. They keep looking. So what you do is you flash that stimulus before they can look. Look at my face, look at my face. How many was that?
2.
Right, there you are. So I'm sure that it was in the periphery. I didn't give it long enough time, give them long enough time to look at it. Now you can do better than that. You can cover one eye. Take a very cooperative person. Let's cover one eye with that thing. And now we're going to test the visual fields in one eye. What I do is I squint the appropriate eye. Here it is, my right eye, his left eye, and I'm going to compare his visual field with my visual field. So we've lined ourselves right up next to each other, and I come in here and I say, when do you see that moving?
I see it.
Good for you. Look right in my eyes.
I see it.
Good for you. Look right in my eyes. I'm comparing his visual field to my visual field. In actual fact, in cooperative people, you can actually find their blind spot that way, which takes a very cooperative kind of person, but you can move this image into a place where the tip of the finger actually disappears. You have to look right in my eye. And once I get into that blind spot, it's actually a tube that goes up and down like this between the two of us. And his blind spot and my blind spot are right lined up with each other. Now this is another example of the reflection technique that I used in the mental status. It depends on me being normal. Right? I'm depending on my being normal. I'm comparing his blind spot and his visual fields with my visual fields. And if you wanted to really become sensitive, you could take a 5mm white-headed stimulus. Look at my face, and I could close one eye or cover one eye, and I could come in here and very precisely map his visual fields and look at his blind spot. But he'd have to be very cooperative. He'd have to really be willing to look at me, not look anywhere else, not to be distractible. So you see there's a spectrum. If he's lying in a bed in the hospital, I can check this visual stimulus. I can do it with both eyes open, make sure he's looking at me. I can do it one eye at a time. I can do it with a small stimulus and find the smallest visual field cut. So it just depends on what you think. If the person's complaining of visual trouble, you'll do this in great detail, very articulate, wide-awake person. If the person's confused in an ICU, you're going to do something entirely different, but you're always going to do something. So there's 3 important components that we did of the second cranial nerve, didn't we? We checked visual acuity with correction or with the pinhole. Then we looked at the fundi, we actually looked at the optic nerve, and then we checked visual fields. So we've checked the second cranial nerve. Now let's check the 3rd, 4th, 6th, and 8th. Let's do them all together. These are the eye movements and the pupils. So we want to see the pupils. I'm looking at his pupils. He has light-colored iris, so it's very easy to see his pupils. You should say how big they are. His pupils, I would say, are 3 millimeters. They're round and they're equal. And then I shine a light in one eye, in his left eye, and I watch it constrict. It constricted directly, that is directly to the light. Then I look at the right eye as I shine the light in the left eye, and it constricts, that's consensual. And third, I want you to hold your thumb about this far from your face. Don't look at it, look at me. Now look at your thumb. And what I see is the eyes come together and the pupils constrict. That's near. So his pupils reacted in 3 ways: direct, consensual, and near. That's what you should say. Don't write PERLA in the chart. PERLA doesn't mean anything. PERLA is an acronym, P-E-R-R-L-A, that you see in a lot of charts. It means pupils equal, reactive, and round to light and accommodation. Not a good idea, because in actual fact, we're not testing accommodation here. Accommodation is the ability to see up close. And that is done by changing the shape of the lens. It requires the constriction of a muscle, a little sympathetic muscle there in the eye. That's called the ciliary body. That has to work. That's not what you're testing. We're testing the reaction of the pupil to near. Remember, the near response has three components: convergence, meiosis, that is constriction of the pupil, and accommodation. What I've just tested is convergence and meiosis. I have not tested accommodation. And I'm not going to test accommodation either, because I'm not an ophthalmologist. I don't have a near card. I can't be sure whether at his age he could see that close, and therefore I'm not going to test it. I'm just going to say the pupils are 3 millimeters. They react to light direct, consensual, and near. So I would pass his pupils. Pupils are normal. I look at his lids next, and the top lid is covering the iris down to the very top of the pupil and not below. They're about equal on the two sides. There's no ptosis, in other words. The eye is not drooping. If one eye were drooping, if I noticed I didn't see the pupil, I would have to decide, is it happening because the levator palpebrae muscle is weak? That's the main muscle that holds the eye up, holds the eyelid up. Or is it because Mueller's muscle is weak? Mueller's muscle is a sympathetic muscle, which is circular and goes around the eye. If Mueller's muscle is weak, the palpebral fissure will be narrow, because the lower lid will be abnormally high and the upper lid will be abnormally low, and so the space will be small. It'll be subtle, not dramatic. And usually, of course, there's a small pupil because it's part of Horner syndrome. So you look at the eye, and it actually gives you the impression that the eye is small. And patients will often say that. They say, I noticed my eye was small. You look at it, the eye is not small. The palpebral fissure is narrow. And you see the pupil's a little smaller on that side. And there's this slight narrowing of the palpebral fissure. That's Horner syndrome. If the levator palpebrae muscle is weak, the upper lid will be down, but the lower lid will be in the normal position, which is below the iris, barely touching it at most. And the upper lid is down, usually much more profound. That's the kind of thing you'll see in a third nerve palsy. And in that side, of course, in that case, the pupil will be dilated on that side, big, not small. Now the question often arises when you see somebody with a smaller pupil on one side than the other, with or without a ptosis, which side is abnormal? Well, so let's say I had found that his right pupil was 5 millimeters and his left pupil was 4 millimeters. Which one's abnormal? Is this one dilated or is this one constricted? How would you find out? Well, the simplest way to find out is to dim the lights in the room. I'm not going to do that here, but we would dim the lights in the room. That would cause his pupils to dilate. That's a powerful stimulus for pupilodilation. If the abnormal pupil is the one which is larger, because it doesn't constrict normally, it'll dilate fine, but it won't constrict normally in bright light. And the reverse is true in bright light. So you can decide which pupil is abnormal by putting the person first in dim light and then in bright light. So if the difference between the two pupils becomes greater in dim light, that means that pupilodilation is the problem. And it's a Horner syndrome. That's the small pupil that's abnormal. And if the reverse is the case, then we say pupiloconstriction must be abnormal. It must be a parasympathetic lesion. It's the large pupil that's abnormal. And if the difference between the two pupils doesn't change, both pupils get bigger in the dim light, both pupils get smaller in the bright light, but the difference between the two remains 1 millimeter, we would say that's normal. That's what we call essential anisocoria. The pupils are unequal, person just is that way. There's very often, as we know, asymmetry between the two sides of the body, and that includes the pupil. So we looked at the pupil, we've looked at the lids, we've looked at the fundi, we've checked the vision, we've checked the visual acuity, and really all that's left is the eye movements. So there's two ways of checking eye movements. First of all, if the person's not complaining of anything about their eye movements or their vision, it's very unlikely you're going to find anything wrong. But if you want to quickly screen it, you say, hold your head still, look right at my face, and now what I'd like you to do is look at the ceiling. Look at the floor, look to the right, look to the left. Those are called saccades. He's saying to himself, I'm going to turn my eyes to the right, and they quickly jerk. Jerk up, jerk down, jerk left, jerk right. Very quick. You can't correct those eye movements until the movement is over. If it goes too far, you got to bring it back. That's a saccade. That comes from the frontal eye fields, front part of the brain. Then I say, hold your head still, don't move your head, follow my finger. And I go slowly back and forth, and now I'm engaging a different eye movement control system. This is called pursuit. He's fixing and following. And in fact, he can control this, correct, right in the middle of the eye movement. I can go faster, I can go slower, and he still very precisely follows. If I go too fast, it'll break down into a series of little jerks, so-called saccadic pursuit. Too fast for the pursuit systems. So I've checked saccades and pursuit. If he comes into me, he says, you know, I'm seeing double. You'd say, okay, what I'd like you to do is show me where you're seeing double the most. And I'll usually give the person the light and say, move it around and tell me where the images are furthest apart. Let's say, for the sake of discussion, that he says to me, when I put the images way over here, when I look over there, I see double. The two images are next to each other. I then simply cover one eye. So he's looking over there. And I covered, let's say, the right eye, and one of those two images will go away. If it's the laterally placed image, that means I have covered the appropriate eye, the one that's weak. Because for optical reasons, the false image always projects laterally. So if he sees double over here, and the leftward image goes away when I cover this eye, I conclude that it's the right medial rectus that's causing his double vision. And the reverse would happen, of course, if I covered this eye and the lateral image went away. I would then conclude that the left lateral rectus is causing the trouble. And that's true regardless of what position the eyes are in. There are always two dominant muscles. So if he looks up to the left, the main muscles that he's using there are the left superior rectus and the right inferior oblique. And the reverse is true here, and again the same, but reverse is true here and here. So there's 6 places to look: up to the left, straight left, down to the left, up to the right, straight left, down to the right. And that's it. That's how you decide what muscle is weak when somebody sees double. Remember, of course, double vision depends on having vision in both eyes. So if somebody is blind in one eye, they can't see double. And so then you have to depend on your looking at the eyes and deciding which one is not moving normally. A good trick for that is to shine your light, your bright light, off the eyes, and look for the reflex, that bright white light that you're going to see in the eye. It should be right in the middle of the pupil. And if the eye's not going fully out, it won't be in the middle of the pupil. You'll be able to see that one eye is not moving normally in one direction or another. If you've lost vision in one eye for whatever reason, you can't see double, doesn't make any difference what's wrong with your eye movements. Remember I told you there was a connection between the 8th cranial nerve and eye movements, and that's called the vestibuloocular reflex. You're aware of the fact that the vestibular system, which is in the inner ear, is connected to the eye movement system, such that when the head goes leftward, there's a stimulus which wants to make the eyes go rightward. It's as if the nervous system is trying to maintain fixation on the object of regard, right? So I'm watching, suddenly my head goes this way, my eyes want to go that way. Now that's suppressed by consciousness. So if I just take his head passively and don't give him any commands and just move it around, he'll actually look wherever I put his head. I turn it leftward, he looks to the left. I turn it rightward, he looks to the right. If I want to see that vestibuloocular reflex in a conscious person like this, I'm going to have to occupy the system that suppresses the vestibuloocular reflex. So the way I do that is I have him look at something, look at my hand. I'm going to move your head passively. And now when I turn his head rightward, his eyes go leftward. When I turn his head up, his eyes go down. So that's the vestibuloocular reflex. If something were wrong with the connection between your vestibular system and your eye movements, that reflex might not be there. If something were wrong up in your cerebral hemispheres, he might not be able to suppress that reflex with consciousness. Meaning, when I turned his head, without the command, his eyes would go the opposite way. So this vestibuloocular reflex can be very helpful, and it's particularly helpful, of course, in people who can't cooperate with us, can't do the rest of the exam. So if I'm seeing somebody in an intensive care unit, they're unconscious, this is something I can do without cooperation. I can check their vestibuloocular reflex. And not only that, if they really won't cooperate and I can't turn their head because they're intubated with an endotracheal tube, or I'm worried that they have a neck injury, I can still stimulate this reflex by putting ice water in one ear, which will temporarily turn off the vestibular system on one side, produce an imbalance, and make the eyes turn. So I can always make the eyes turn provided the systems are there to make them turn. So that allows me to test this system even in somebody who absolutely cannot cooperate with me. So I'm finished with cranial nerves now, 2, 3, 4, 6, and 8. We're almost there. Now we skipped the 5th though, didn't we? 2, 3, 4, 6. What about the 5th? Well, the 5th has multiple functions, but its main function is sensation on the face. Most people with a 5th nerve problem complain about it. They say something's wrong with my face is burning, I'm numb here, I don't feel my razor on my face, something to that effect. And so I don't test it in detail unless the person really complains of something. In fact, you can suggest things to people who are otherwise normal if you do what I call microneurology. You know, looking for things that are so fine that they're insignificant. I like to say there's no real microneurology, there's just microneurologists, small neurologists. I think it's not a good idea to say to somebody, here's a normal guy, if this is $1, worth $1, how much is this worth? What would you say?
Also $1?
Be careful now, man. Don't make a mistake. If this is $1, how much is this?
Maybe 75 cents.
Well, see, so I now suggested a sensory loss on his face. And we know that he doesn't have a sensory loss on his face. And you can see that if you were a little nervous, anxious, and the doctor says, well, be very careful, be very careful, tell me the best answer you can. People will start to say, well, I don't know, 98, 96, and now you've got a false positive. Does this feel about normal to you on the two sides?
Mm-hmm. Good.
That's all I do in a person who's obviously normal and who's not complaining of anything. I think if you do more than that, you're looking for trouble. Now, if there is trouble, sensory loss in the face, you want to test it. One good way of doing it is to use a noxious stimulus. This is a tickle. Tickle is very noxious. It's a kind of pain. So if you have a person that says that the left side of their face is numb, you might just come up and tickle them in the nose. You see what he did. Jumped away. It's not pleasant. Jumped away. I can decide whether there, quote, really is a sensory loss on that side of the face by that. And another way to do this is something called the corneal reflex. Very important thing to understand how to do. So I want you to look up at my finger and keep looking at it. Just keep looking. I'm not going to hurt you. Just keep looking at it, keep looking at it, keep looking at it. So what I did is I touched the cornea on the right and both eyes blinked. Now that reflex is caused by an afferent limb which goes in the 5th nerve on the right, gets to the brainstem, goes to the 7th nerve nuclei on both sides, both eyes blink. A 5-7 reflex. Can do it without anybody's cooperation. Notice the eye blinked direct and consensual, very much like the pupil. So if this eye, for example, the right eye, didn't blink, and I was trying to decide, is it the 5th or the 7th that's causing the failure of that eye to blink, this would be very useful, wouldn't it? If I touched the right cornea, and the right side and the left side failed to blink, I would conclude it's a sensory problem, wouldn't I? The 5th nerve on the right is not working. If, however, I touched here like this and one of the other side didn't close, that would be a 7th nerve problem on the opposite side. So I can separate a 5th from a 7th by doing this corneal reflex. And it's a very irritating sensation. You can see that he smiles when I do that. You can test sensation all over the face without hurting people, and yet it's a noxious stimulus. You can also use cold. I don't think you need to poke people with pins, which these days is actually dangerous. You feel that cold on both sides of your face. And of course, a very important test to try to separate somebody who has a psychogenic cause of numbness on their face from a real cause is to tap the tuning fork and say, which is greater? Are these equal or different on the two sides?
Equal.
They're equal. Now, if he were a person saying to me, you know, I'm numb on the right side of my face, what I would then do is I would put this tuning fork on his forehead, recognizing that that's only one bone there, right? And that vibration would be carried right across to the other side. And if he said to me, I only feel it on the left, that's not physiological, right? The nervous system can't actually do that. And that indicates to me that he's making that up. He's saying that he's not feeling it, but actually he must be feeling it. That's a very, very, very important test to try to decide whether somebody who says that there's something wrong with sensation on their face actually has something wrong. Now the fifth nerve does other things, but they're hard to test. Muscles of mastication, these big muscles in the jaw, are also fifth nerve. It's tough to know whether they're weak. Put your teeth down really tight. I feel the masseters there. Can you move your jaw back and forth? These are the pterygoids, very strong. Open your jaw and don't let me close it. It's very strong. I must tell you, I have a hard time ever finding anything wrong with those muscles. They're so powerful. And then we get to the seventh nerve. The seventh has many different functions, but its most important function are the muscles of facial expression. We already talked about some of them, the ones that blink the eye during the corneal reflex, but all the muscles of the face that make the face have expression are seventh nerve innervated. And the main point here, of course, that all of you have probably learned and tried to apply is the difference between an infranuclear and a supranuclear disorder. This is very important in all of neurology. You can learn it best with regard to the seventh. An infranuclear disorder means the disorder is in the nucleus or something distal to that, in the nerve itself, or in the neuromuscular junction, or in the muscle. Infranuclear lesion means that everything in the distribution of those motor neurons is affected. So if I have an infranuclear facial nerve palsy on the left, his whole face will be weak. His forehead will be flat, his eye will be hanging open, the corner of his mouth will be drooping, and he will not be able to correct that no matter what he does. If he spontaneously laughs, you'll see this very distorted face. If he tries to puff out his cheeks, you'll see this very distorted face. It won't change no matter what. If the lesion is supranuclear, that is up in the cortex where the face is represented, it turns out that the forehead is bilaterally innervated and will be relatively spared. So somebody with a stroke in the right hemisphere producing left-sided facial weakness will have a weak face, but the forehead will be spared. You'll see the folds in the forehead. So you often say to people, look up at the ceiling. And when he looks up at the ceiling, you can see the folds in his forehead and the eyelids go up. In a person with a stroke kind of facial weakness, supranuclear facial weakness, that will work fine. But in somebody with Bell palsy, an infranuclear lesion of the seventh nerve, an infection of the seventh nerve probably by a virus, that will not work. The forehead will not work, the cheek will not work, the whole thing will not work. Thanks. The other functions of the seventh nerve are harder to test, and we test them only in specialized circumstances. Sense of taste on the anterior two-thirds of the tongue, carried in the seventh nerve. In people with Bell's palsy, that's affected. They'll often say to you, things taste metallic. And you can test it. I'm not going to test it today. You would have to put solutions of salt and sweet and bitter on the tongue. It's not an enormous amount of trouble, but it's more trouble than you usually need to go through. And another function of that seventh nerve is to innervate a little nerve called the stapedius muscle, nerve to the stapedius muscle, which tampons down sounds after they start to shake the tympanic membrane. If you don't have that function, you'll have what we call hyperacusis. Loud sounds will bother you. And people will say that. They'll say, I don't like loud sounds, and if I come up with my tuning fork and I just check the two sides, you'll see them wince as if I just put that tickle sensation on one side. They can't tamp down the sounds. In somebody with Bell palsy, they have all these things. They have a taste problem on that side of the tongue, they have hyperacusis, and they have an infranuclear facial weakness. The whole face is weak. It's usually pretty easy to recognize that kind of thing. So those are the main features of the seventh nerve. The eighth nerve we talked about a little bit already, haven't we? Because we use the eye movements and the vestibuloocular reflex, but you should know about the other component of the eighth nerve, and that's hearing. That's the cochlear component of the vestibulocochlear nerve. It's a nerve with one Roman numeral but two functions, vestibular and cochlear. How do we test hearing? We test it in 3 steps. Step 1, is there deafness? Most people will tell you this. They'll say, I'm having trouble listening to the telephone with my left ear. I mean, it's just difficult for me. But if they don't know it, you'll test it. I have a adjustable tuning fork that saves me trouble. It's set here at 64 cycles per second. I can move it to 128. These are C's on the piano, 256 or 512. If you're going to test hearing in a young guy like this, you ought to start With the 256, 512 is very high-pitched. As people grow older, normal people lose it. And 128 cycle per second is a vibratory stimulus, as you'll hear when we talk about that later. It's not a good, it also stimulates the auditory nerve, but not as specifically as 256. So can you hear that on the two sides?
Yes.
So he doesn't have hearing loss. I wouldn't really go on in this situation, but let's make believe he does have hearing loss in the left ear. I would want to know whether that hearing loss is due to trouble in the nerve or trouble in the middle ear, so-called conductive hearing loss. Remember, there's three little bones in the middle ear, malleus, incus, stapes. They magnify the sound through the middle ear. If there's fluid in there or something, you'd have a conductive hearing loss. So remember, these three little bones make air conduction better than bone conduction. That is, we hear better in front of the ear than we do over the bone. Let's test that. Which is louder, number 1 or number 2?
Number 2.
No question about it, right? Easy to tell the difference. Air is better than bone conduction. That's normal. If he were deaf in this ear, and I found the relationship between the two was normal, air is greater than bone conduction, I would conclude that he does not have a conductive hearing loss. Does not have it. And he has a sensory neural hearing loss, at which point I would do one last test of hearing. I would test speech discrimination. Let's test that. I'm going to make a noise in the left ear so he doesn't hear my whispering. I'm going to whisper words in the right ear. And let's hear if he can tell what these words are. Repeat them. Hot dog.
Hot dog.
Ice cream.
Ice cream.
Peanuts.
Peanuts.
Good. That's correct. I would give him 10 words in each ear. If he were 2 out of 10 correct in this ear, 8 out of 10 correct in the right ear, I would conclude that his sensory neural hearing loss in that left ear is what we call retrocochlear. That is not in the cochlea, but somewhere in the nerve or the central nervous system. And that's very important to us because neurological diseases like acoustic schwannomas, vestibular schwannomas, they would cause a retrocochlear hearing loss. So we have a 3-step process. Let me review that. We decide, is there hearing loss? If there is hearing loss, we decide whether air is greater than bone conduction, 1 or 2. And if air is greater than bone conduction, we do speech discrimination to decide whether it's cochlear or retrocochlear. This test that I just showed you is called the Rinne test. There's another one called the Weber, and I'm going to show you why I don't do the Weber. Where do you hear the sound?
My right ear.
Where do you hear the sound now?
My right
Not
ear again.
feel, but hear. Now.
Behind me?
Yeah, so here's a very, very accurate observer in a very quiet environment having a very hard time giving me the answer to these questions. Most people do this thing on a noisy ward. There's airplanes flying over. You're asking people about this. It'll work if it's done by an audiologist in an absolutely quiet environment done exactly right. It doesn't work in clinical practice very well. I don't do the Weber test. I do only the Rinne. And I also don't do it the way most of you learned it, which is this. Tell me when it stops, when you can't hear it anymore.
I can't hear it anymore.
Can you hear it now?
No.
You see, it didn't work, did it? And yet, it was very easy for him to tell which is louder, 1 or 2. 1 or 2.
2.
No question. So you see, waiting until it disappears is not very accurate. The dissipation of the vibration is not linear, and within that time that it takes from moving it from here to here, it may disappear completely. And then you've got a false positive. So do it the way I showed you, air better than bone conduction, 3-step hearing test. That's the auditory nerve. So we're now down to the bottom of the cranial nerves. There's not that many clusters left. 2 more. One cluster of cranial nerves involves the speaking and swallowing, the palate, the tongue, the lips. The truth is I've already tested this, haven't I? I took a history from this guy. I've heard him talk. He speaks perfectly normally. He makes lingual sounds. He makes buccal sounds, B's. He makes guttural sounds, G's. They all come together correctly. They're coordinated well. I don't actually have to do anything more than that. People who begin to have trouble with those cranial nerves, long before you can see anything wrong with the palate, the tongue, and the lips, you'll begin to hear some kind of dysarthria. This is lingual dysosmia. You see, my tongue is not moving normally. And if my palate doesn't move normally, you'll begin to hear a nasal sound like this. And furthermore, the patient will be coughing. Excuse me, doctor. Because they're choking. And they're often carrying a handkerchief or a Kleenex in their hand. That makes the hair stand up in the back of my neck when I see that, because that smells of a motor neuron disease, doesn't it? This person is having the insidious onset of trouble with their tongue and mouth and palate and lips and swallowing mechanism. Now you don't really have to look to know it. Now a guy like this who sounds perfectly normal, is it really worth it to look in the back of his throat and wonder where the uvula is? Probably not. Let's do it just to see. Say ah. So I'm looking at the uvula. Look at the line, not the uvula. Uvula may sag rightward, it may sag leftward, it means nothing. Look at that raphe. It should go up like that. If it's weak on one side, it'll be pulled to the other side, to the strong side. But we would have heard a nasal speech, and we didn't. Tongue, let's see your tongue. Tongues move. You see, even his tongue is moving. Nice young guy. See it moving like that? Don't worry about that. That's nothing. That doesn't mean anything. It's amazing. Patients get very worried. Doctors staring at their tongue. They go home and look at the mirror for hours. You know, what's wrong with my tongue? Nothing's wrong with it. Listen how normal it works. There's nothing wrong with it. That's what the tongue looks like. If you open your mouth and don't put your tongue out, and I look at it in the floor of your mouth, it's moving around a little bit. By the time the tongue really is atrophied and wasted, people have terrible trouble with speech. Terrible trouble. It doesn't take Charcot to tell it's something wrong with their speech. So listen carefully, look briefly, and don't overreact to a tongue that looks a little different than you're used to looking at. Push your tongue against my finger. Push it against my finger. Say la 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 la.
La 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 la.
Ta 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 ta.
Ta 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 ta.
Ba 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 ba.
Ba 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 ba.
Ga 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 ga.
Ga 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 ga.
Good. Say po po catepital.
Po po catepital.
Tippy can canoe.
Tippy can canoe.
Puckety 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 like that.
Puckety 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 puckety.
If he had cerebellar trouble with his speech, he would not be able to put the emphasis in the right place. Puckety 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 puckety. La 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 la. Is how it would sound. I already knew that, of course, because I listened to his speech, but you could test it in that way if you felt like it. So now we've tested the cranial nerves 9, 10, and 12. And that leaves us only with the very last, the 11th. The 11th is an unusual one. It comes from a branchial arch, and it innervates two muscles, the sternocleidomastoid and the trapezius muscles, which are big muscles involved in the movement of the head and neck. Again, I don't check them unless there's a specific reason for it. But if you want to test them, a good way is to stand back and say, shrug your shoulders. I'm looking for how quickly and symmetrically they come up. Pushing against them, don't let me push it down, is not a good idea. In the first place, what's my chance that I can overcome these muscles in this guy? Zero. I mean, he's wimpy. Neurologist, here's a big, strong guy. There's no chance. He could be 50% weak, and I would not know it. I've had this happen to me where a big weightlifter guy said to me I was weak in this deltoid muscle, and I couldn't find it, but he was. He knew that he was weak. He's just still 10 times stronger than I am, right? That doesn't pay. And the reverse of that is even worse. You take a tiny little old lady, 75 pounds, and you say, push down hard as you can, push, push. All of a sudden you hear crack. Literally. I mean, little osteoporotic bone. You've broken a bone testing your strength. Not necessary. Watch the nervous system do its own thing. Raise your shoulders. Turn your head to the right, the left. Flex it forward, all the way back. Good. If you wanted to test it gently, relax. Push hard. Watch both sternocleidomastoid muscles stand out. Turn your head to the right, hold it. Don't let me turn it back. See it stand out? Turn it to the left and hold it. Shrug your shoulders and hold it. I've tested the sternocleidomastoid and trapezius muscles. I'm finished. We've tested all 12 cranial nerves. We've tested them in clusters, which help us to remember what they're really for, not some mnemonic that has absolutely no meaning to you. And you can see why it's still important, even in the 21st century, to harken back to our ancestors in neurology and do the cranial nerves as an intrinsic part of the basic neurological examination.